So I'm going to talk about psilocybin therapy and its promise for treating mental health conditions. I can't believe I'm going to be the first person to give one of these disclaimers. Read quickly, guys. Go for it, because we're going to move straight on onto the talk. So I think it's really cool, actually, to take a bit of time to think about mental health. And you know, the best way to start this is to say we all have a story when it comes to mental health. I wouldn't be surprised if there's a significant number of people in this room who are personally affected by mental health problems. I would definitely believe that the majority of you guys have friends or family who have mental health problems. It's so prevalent in society, and it's actually one of the reasons why Compass as a company was founded in the first place, from the co-founders' experiences of treatment-resistant depression and engaging with mental health care systems that, quite frankly, are inadequate. There's such unmet needs and burden that we have to deal with when it comes to mental health. The lived experience, the patients, what do they say? Depression at the time I was diagnosed was taking a huge toll on my life. I was having a hard time eating and sleeping. Negative thoughts were in a loop in my head that made it hard for me to work and focus, concentrate, and also made it difficult for me to engage with people I love. My family, my friends, I isolated, I withdrew. It really took away so much of the joy in my life. Pretty serious words, really. It kind of pales into comparison the kind of moments of kind of downness that everyone has. I went through a range of negative affect yesterday, waiting in Heathrow Airport for 10 hours for a plane, but this is next level stuff. This is black, deep despair, which quite frankly gets even worse when you think about the fact for many people, there are no treatment options at the moment. Treatment-resistant depression is a form of depression, and the definition I'm going to use today is it's a depression that doesn't improve after 2 or more antidepressant treatments, be they pharmacology or otherwise, within a single depressive episode. You can imagine the burden that this is having on patients and their families, having to deal with this for what can be years on end. I don't really want to dwell on numbers and money and stuff. I think the key statistic here that I find quite sobering is the one around suicide, where 30% of people are attempting suicide at least once during their lifetime as a consequence of this disorder. That's pretty sobering when you think about it, and you know, we need to try and do something to help there. So here comes Compass with COMP360 psilocybin therapy. So COMP360 is our proprietary formulation of psilocybin. It's a synthetic form of psilocybin. No mushrooms are harmed in the making of COMP360. And we've just recently had some great news where we've completed a phase 2b trial in treatment-resistant depression and found that a single dose, at least for some people, has rapid and enduring efficacy in alleviating their symptoms of depression. Really quite remarkable in some ways as well. So we're on the beginning of the journey of hopefully developing COMP and bringing it to the market for the patients. I think it's important to think about how this therapy is actually applied. This is not your typical go to the doctor, get some pills and go back and take them once a day and probably for the rest of your life. This is quite a different approach. So the psilocybin therapy model, I guess by the very nature of the fact that you're inducing a psychedelic experience, it has to happen inpatient. And the patients develop a therapeutic alliance with a therapist who's with them for the 3 stages of the journey, where at some point before the session, they get some preparation, they get some psychoeducation about what they're going to experience, what's going to happen to them. The therapist actually sits in the session as they're dosed. A psilocybin psychedelic experience is approximately 6 to 8 hours, and the therapist is there for you during that period. Very important to point out, it's not psychotherapy, it's non-directive psychological support. We expect the drug to do all the work here, basically. It's not about combining drug plus psychotherapeutic approaches here. The therapist basically will help the person should they have any moments of intensity, basically, to ground them a little bit and bring them back to a more solid baseline. And then at some point in the preceding days, you have an integration session with your therapist, where you basically just talk through what happened, what did that mean to me, how am I going to use that in my life moving forwards. And it's so far in phase 2B at least, it's the beginning of the journey, but it's had some cracking effects. So this was the work that was published in the paper I just showed you guys. And this is the biggest controlled trial of a psychedelic drug to date. There was 260 people, I think, involved in this. Don't quote me on that, but something like that. And it's important to note that it was a controlled double-blind trial. You'll note it's not placebo-controlled, because placebo in this context gives all sorts of issues around anticipation and expectancy bias and stuff. So the way that we controlled in this study was to use 3 doses of the drug itself, a low dose that really should have no effect, a middling dose, and a high dose. So at least in terms of informed consent, every patient thinks they're receiving a dose of psychedelic. And the results, as I say, were pretty cool. So we see almost immediate reduction in depressive symptoms as measured by the MADRS scale in this particular study. It was a large effect, certainly at the 25 mg dose, and it was durable. So this study went out to week 12, and there was still a significant number of patients after a single dose that we're seeing enduring efficacy. Long-term follow-up is still ongoing, and it's looking like that efficacy might sustain for months for at least a number of patients. So the experience, I think, without fear of contradiction, can be really intensely memorable and meaningful for people. Single doses can have life-changing effects. And this window is here for a reason. This is the rose window of the Mars Chapel in Boston, which was where a very interesting study happened in the 60s by a chap called Walter Pank. You guys might have heard of it. It's called the Good Friday experiment, where he did a controlled trial in trainee priests on Good Friday, where half the priests received psilocybin and the other half received placebo. And they've tracked these people, and they talk about this being up there as one of the most significant things that's happened to them. Roland Griffiths has also done similar type of work. And again, years after the experience, people are saying the experience of taking a psychedelic in that type of context is up there as one of the kind of existential high or low points, you know, births, deaths, marriages, in terms of the impact it can have on a person. So pretty significant stuff. Psychedelic itself, the term means to manifest the mind. It was coined by Humphrey Osmond in the 50s. And it's quite interesting to think there's been a bit of discussion already about subjectivity and objectivity. Psychedelics possibly takes this to a different level of subjectivity, where the experience itself can be ineffable. There's actually no words that you can think of to describe what just happened to you. So that poses a challenge for neuroscience in some ways, but there has been a lot of work done on how to try and bring as much objectivity into the measurement of these states as possible. And this is where measures like the 5D ASC come into play, so the 5-dimensional altered states of consciousness questionnaire, which is used a lot in the context of psychedelics, but it looks to hold consistently true across a range of other different types of experiences that can alter one's state of consciousness. It's something like 95 questions that split into 11 different dimensions, but it's called the 5-dimensional altered state scale, but people only look at 3 key dimensions, so go figure, complicated stuff. It's important to think how psychedelics differ from other agents like dissociatives and empathogens. So you can see in this spider plot here, things like ketamine, for instance, the orange bar, it loads more in the kind of dissociative disembodiment type feelings, whereas empathogens like MDMA, you see that really prominent spike in blissful state. So these compounds are really quite qualitatively distinct from each other. A term that you might hear often, well, actually, maybe not so much now, is psycholytic, which is another term for psychedelics when they're used in lower dose and combined with psychotherapy. Um, I'm not a big fan of the term hallucinogen. Psychedelics don't cause classical hallucinations because you're always aware of the physical unreality of what you're experiencing. You can easily be snapped back to reality in a way that, say, someone with florid psychosis would not be. So that's how we kind of principally measure the psychedelic experience. I'm going to speed through this one because there's a lot on this slide, but basically, elements of the chemistry here are fairly well described. This is a level of chemistry that even I can understand, and I normally need an adult to take me through this type of stuff, where psilocybin basically is very true to the tryptamine backbone that you can see in serotonin at the top, so 5-hydroxytryptamine. Psilocybin is actually a prodrug, which is dephosphorylated in your system to become psilocin. That's the active agent, which is 4-hydroxydimethyltryptamine, so not a million miles away from serotonin itself, but has hugely different effects in a person. It's very stating the obvious to a crowd of neuroscientists, serotonin projection systems in the brain are really quite incredible. I don't know if you guys have ever seen any tracing studies looking at individual 5-HT neurons coming up from the Raphi nuclei. They're huge, huge neurons that basically cover the entire cortical mantle. And you can see from the 5-HT2A cortical distribution that's a system that basically can engage the entire cortex. I'm talking a lot about 2A. 2A does seem to be a necessary component of the induction of a psychedelic experience. And there's been some recent structural biology studies now where we can see the little orange blob there is psilocin, nice and cozy in its binding pocket in the 2A receptor itself. Maybe the final thing to say about the 2A system is often, even as neuroscientists, we always think about that classic pre and post synaptic transmission thing happening. There's a lot of aspects of serotonergic transmission that are much more about volume transmission. Some of the key receptors, the 2A receptors in pyramidal neurons, they have a somatodendritic location principally. So they're doing quite a different job in terms of controlling the electrical excitability of those neurons, and that's why you see that classic recurrent lateral disinhibition after a dose of psychedelic. Anyone who's read about psychedelics recently has probably seen this graph. I think it's a really interesting figure. It almost does the experience poetic justice as well in terms of trying to represent what is happening in your brain after a dose of psychedelics. So we know we're engaging 2A receptors. It's causing this recurrent cortical disinhibition to happen. And what really seems to be happening is a kind of global decoherence of resting state networks in the brain. Your brain, at least for a period, is just becoming more connected, more noisy. Some people talk about it as like the snow globe effect. And there's some interesting theories around entropic brain states and relaxation of beliefs, etc. So the rebus model that Robin talks about. So what you're basically seeing is classic resting state networks are becoming less well segregated. So everything is just kind of connecting in a very transient but impactful way. And two networks that are of particular importance here are the DMN and the ECN. So the DMN, the default mode network, and the ECN, the executive control network. And it's interesting that as these networks decohere during the experience, after the experience, during that kind of integration period, if you will, the networks come back and can be even more prominently engaged with each other. So the ECN, you'll hear, and I'll talk a lot about the DMN, but the ECN does also look to be a very important network to be re-engaged in terms of giving people the drive to then do something about what they've just experienced. So DMN, I'm I'm sure you guys all know the story about the DMN, where originally it looked like it was an artifact that was appearing in functional imaging studies. And then folks gradually realized it's a distributed network in the brain that actually seems to be most active when you're not really doing much. So when you're daydreaming or ruminating. And it basically does look like it's a plausible neuroanatomical, neurophysiological substrate that at least has an element of the basis of yourself and related to, you could almost see it as like the highest level of cortical function that happens to actually make self happen. So in more controlled studies, you see the DMN engaged when you're thinking about yourself, thinking about others, remembering the past, thinking about the future, all sorts of things to do with yourself and your agency and the role that yourself plays in the world. I think it's really interesting to think about the self. In some ways, it's not a topic that's been that prominent in neuroscience for a long time, but I think it's time to have a little bit of a kind of resurgence of thinking about the construct of the self and how it actually is probably fundamentally important to many neuropsychiatric disorders, not just depression, but many other disorders where there is something dysfunctional happening to your notion of yourself itself. This review by Davey and Harrison, I would strongly recommend you read. It's a new kind of appraisal and thought piece around the role that the self plays in depression itself, and they talk about differences between the experiential self and the narrative self, and this kind of cuts across so many things we've heard today around things like inflammation, around vagal nerve stimulation, the peripheral role that can play into the notion of the self. So the experiential self is the self that exists when you're not thinking about the self. It's just all the interoceptive cues that are kind of fading upwards in a way. And then you have the narrative self, which is the kind of construct that you impose upon yourself, your autobiography, how you would look at someone else and think they have a self. That's a narrative self. And I think the key change here is to think about these things holistically, that you can impact probably any level of this axis of function, and then it will impact on other levels. So what might start as a period of bad insomnia for someone might end up becoming excessive rumination that then starts to change your mood, and then you can see how it all starts to compound in itself. And perhaps if you have a genetic predisposition, then that might be the onset of a full-blown depression for you. So depression is interesting. DSM-5 has a number of different categories, and you have to display at least some of these symptoms in order to be considered to be depressed. But if you look at the number of combinations of these factors that can happen, there's hundreds of different ways one can be diagnosed as being depressed. I like the idea that you can somehow bring the self back into this, and this can kind of cut across what's actually happening pathologically and in a kind of useful way for setting up new hypotheses. So I guess the hypothesis is that the subjective psychedelic experience may actually serve as a kind of inflection point in your life. So it's giving you an opportunity to actually fundamentally change the way you're thinking and feeling and ultimately behaving. It gives you that mechanism for change. So this is a great place to be as a preclinical neuroscientist, because we have a molecule, we have a pharmacological class that still is relatively not well understood, but is showing great clinical promise. There's a fantastic opportunity for us to go in there now and try and actually work out what's going on. So we know from the phase 2 trial that we can see dose-dependent increases in psychedelic experience, which ultimately cause long-term efficacy. So going out 3 months plus, we can see changes in depression for folks. So the key thing as a preclinical person is what can we do to understand what's happening in the intervening time after day 1 and before month 3. And really for me, as a preclinician, I'm interested in whether rodents can help us understand this or not. Top question, can rodents have psychedelic experiences? I'm not expecting you to answer, by the way. But it does lead to all sorts of interesting, shall we say, bar debates around the nature of consciousness and self and rumination and what have you. But what you can do is you can give animals psychedelic drugs and see what happens. And the classic thing that does happen is called a head twitch response, which this is a slowed down video, by the way. It's really hard to actually observe if you're not into your behavioral work. And it's basically almost the equivalent response as to when you kind of tickle a mouse's ear, if you've ever done that. It's just a little shake. In rats, it can be a bit more expressive. It can be a wet dog shake that basically runs down the whole body. We still don't know to this day why this happens, what exactly the substrate for this is, other than it seems to involve two receptors. And it most definitely tells us something about psychedelics. So you don't often see correlations as nice as this, but this is some work by Adam Halberstadt, where he's looking at the potency of different psychedelics to induce head twitch versus their potency as psychedelic agents in humans. And it's pretty much a near perfect correlation. So whatever this is, it's telling us something about 2A engagement and relating it back to the human experience. And we can go a bit deeper, obviously, with pharmacology and genetic work, and we can show that this effect is dependent on 2 receptors, but there's a whole other talk about how much more complicated this gets, but that's for another time. I guess I should also say the elephant in the room here is I'm only talking about 2A, but psilocybin and many other psychedelics hit half a dozen to a dozen other receptors, and that almost certainly influences exactly what's happening during the experience. The other way that you could think about trying to bring some objectivity into work and translational opportunity as well is to use some classic electrophysiological approaches. And I've pulled 2 examples of work here. The top graph is actually a MEG study on psilocybin, and the bottom graph is an EEG study that Compass conducted in rats. And I don't want to read too much into this other than to say that there is that translational opportunity there, and you can see this classic finding that seems to happen in both cases, considering the spectral profiles here, that psilocybin is causing this dropout in low broadband activity. Now, you can go down a kind of path of trying to work out whether that tells you something about efficacy, or you could go down a more pragmatic path of saying, as long as it looks the same, then we know that we're confident that we've got a dose we can take into humans, for instance. Either way is probably valid. Definitely useful, I think, to consider in combination with some of the behavioral pharmacological work as well. But it's maybe not quite enough. How are we going to move from the psychedelic experience to long-term efficacy and avoid all that stuff that you've seen in the past about animal models of depression and the number of high-impact papers that have fantastic molecular biology and then they finish it with a forced swim test? You're like, really, guys, we need to get past that and try something a bit more translational. And we take a lot of inspiration from the Research Domains Criteria Initiative, which has now been adapted in this great review to kind of extrapolate onto psychedelic therapy constructs. So Research Domains is basically trying to ignore psychiatric diagnoses of disease and to think more about the fundamental psychological subdomains that we can meaningfully study and impact in animals as well. So one example of how this works is in terms of negative affective bias states. Beata talked a bit about this facial emotional recognition stuff already in humans, where you can see basically depressed people have a bias towards negative things in life. They don't see the happiness. They see more sadness than happiness. And you can effectively do the same thing in animals, where working with Emma Robinson in her lab in Bristol, She's helped to develop this rodent affective bias test, where animals are digging in bowls for food reward. And what you do is, on some training days, you train one bowl, say the bowl with the little bibbles is trained with a feeling of being anxious. And then on another day, the bowl with the little scrunchies is just trained as a normal, baseline feeling. And then you present the animals with the bibbles and the scrunchies and say, what is it you want to have today? And they will bias one way or the other. And basically, what you can see with psilocybin and ketamine as well, to be fair, is that one day after dosing, so this is not an immediate effect, one day after dosing, you can see that there's a bias in the preference that the animals have for the bibbles or the scrunchies. That's really important in terms of helping us go from psychedelic experience to sustained responses to actually understand the substrates for efficacy. Final slide. There's still a lot to think about and learn here. I think there is some very plausible neuroscience that can take you from an acute single psychedelic experience through to a long-term behavioral change in humans. But some other things we do need to think about. There is a debate in the community at the moment as to whether the psychedelic experience really is necessary or not, whether there's some underlying other mechanistic thing at play, be it plasticity or neuroinflammation, that could actually be underpinning efficacy here. As we find this out, we will understand the mechanism of change, and we might actually get to a point where we'll know who's going to respond, what factors are going to predict the response, and ultimately, hopefully, whom else may actually benefit from these types of therapies. There is a real sense here that this could be a transdiagnostic opportunity we have, and that some of the efficacy that's being seen here might play out into different disease states as well. But we'll let the data decide for itself where it's going to take us, I think. And with that, I'll probably just end on this quote, which was from one of our phase 2b trial patients. I feel like I'm living again. I feel like this is one of the greatest gifts that I've been giving. And I guess this is a time of gift giving and a time for hope and mental health. So it's a good note to end on, I think. Thank you, guys.